Hi, my name is Brian Lefferts. I'll be talking to you about my project to improve patient access to care at YKHC. This was a two-part project spanning two different semesters. I started it last summer. In the first phase, I analyzed how we identify patients to be seen, schedule that care, and ensure follow-up. In phase two, I did a gap analysis and then developed a project plan to address one of the biggest barriers to access to care, which was the scheduling system at our remote village clinic sites. So a little bit about YKHC, the Yukon-Kuskokwim Health Corporation, where I work. We're a tribal health organization located in southwestern Alaska. We serve 30,000 residents and provide over 99% of the medical care in the region. We're located about 400 miles west of Anchorage, and some unique thing about our region is there's no roads to the YK Delta or between any of the communities here, including where the hospital is located and any of the surrounding villages. There's 50 different villages in the region. You can see a map of the area in the top right corner. And then that's a region about the size of Oregon. You can see there on the inlay of Alaska, where the red box on the state of Alaska. And there's 50 villages here. They're all staffed with they all have a small village health clinic staffed by a community health aide who's trained in preventative health and emergency response, but also has some chronic care skills depending on how far they've made it through their training. We have 5 sub-regional clinics. You can see the different colors on the map, and then to the left of that map is an example of one of our sub-regional clinics. The hospital in Bethel is a 50 bed hospital here, and we also have a large ambulatory program with physicians and more advanced practice providers. And then there's an example on the bottom right of one of our small village health clinics. All of the programs at YKHC operate with a shared mission of working together to achieve excellent health. One of our strategic visions for our organization is improving access to care and providing services as close to home as possible. Without a unified approach to identifying, scheduling, and following up with patients, there is a potential for missed opportunities and inconsistent care. So this project was designed to assess how patients are identified, scheduled, and follow up with across the different programs, identify gaps and inefficiencies and missed opportunities in that current workflow, and then build a foundation for standardized scheduling and follow-up care moving forward. This matters because missed appointments and delayed in care aren't just operational problems, they lead to worse health outcomes, especially in settings like what we see in the Yukon-Kuskokwim Delta, where there's very limited access to care. So to work on this problem, I'm accomplishing this through a couple different approaches. First, to understand all the ways that patients are identified, scheduled for appointments, and how follow-up care is made, I conducted a series of interviews with administrators and frontline staff from lots of different programs. There were 24 open-ended questions, and I used the answers from that to map out all the different process flows and find out what parts of the different scheduling and follow-up process flows that individuals liked and didn't like. I then also developed some quantitative reports looking at the total number of visits, total patients, number of provider days spent in Bethel, a bunch of different, looked at it by appointment types and how many days in advance of those appointments that the appointments were made. I shared these results afterwards. I analyzed that, compared practices across sites, and then shared these results with a cross-disciplinary team, and including the community health aid program, itinerant program, which travels out to villages, outpatient care, public health, specialty care, and the sub-regional clinics, and then met with leadership about it. Because only one team was not using the electronic health record system to schedule appointments, and because that team accounted for about a third of the total visits, and we often scheduled multiple departments at their locations, we chose to focus our efforts on developing a scheduling system for the village health clinics there. And to start with, we created a shared definition of the problem. We reviewed all the existing solutions, identified what that new improved system should look like, and developed a prototype, tested it, modified it, and then created an implementation team. And I pulled together a work group of about 25 different individuals from across different departments to accomplish this. We got started by coming up with a shared definition of the problem, and we met and listed all the issues that everyone had with the existing system, and then came up with this shared definition. Patients and staff need a reliable process for creating, tracking, and completing appointments because gaps in scheduling processes result in delayed or missed care, poor outcomes, inefficiencies, and patient and staff frustration. We then had a visioning session where we identified all the parameters that a new scheduling system would need to include when we were designing the new system. We then met to build a prototype. We reviewed all the different scheduling systems that were currently in use across the organization. And although a lot of different departments use the same appointment books, each department customizes them to meet their own needs. So we wanted to pick and choose ones that would, from all of those, in a way that would work best for our village health clinics. After creating the prototype, we then tested the solution out. We filled up the schedule with a bunch of test patients, and then came up with a whole bunch of scenarios that the team had run across in the past that caused problems, and then tested how the system would respond to all of those different issues. After testing out the system, we then modified it a little bit to account for some of the issues that were identified from that testing. After creating a system that worked, we then developed an implementation and rollout plan. We decided to pilot this in 4 village health clinics to start with, and then we created 4 different rollout teams. A team to build out all the scheduling templates in all 40 remaining village health clinics, a team that could create training guides and competencies, a team that would then communicate this new system out to the rest of the organization so that they could utilize it to schedule patients that they have in their from their respected sites that need to be seen in the village health clinics, and then an implementation and accountability team. So the final products started by doing an analysis of the system overview, summarized how all the different patients access care across our organizations, did a gap analysis to identify and document all the different workflows, potential missed opportunities, and compare them across all the different departments at YKHC. Then brought together a multidisciplinary team to look at how we could improve the scheduling workflow at the remote village health clinics, which were causing the majority of the issues with scheduling, and then came up with a pilot project and to test that in 4 village health clinics, and then a project rollout plan to implement the new electronic scheduling workflow across the organization. So this is going to help our organization because we now have a clear understanding of the existing system. We have some baseline data on where our scheduling data on how many patients are being seen and how far in advance they're scheduled. And then we developed stakeholder engagement for the process improvement that involved multiple departments so that there's excitement about implementing the changes that are taking place. So some of the competencies that this addressed were designing and conducting a mixed method evaluation. So I did qualitative and quantitative data analysis, promoted interprofessional approaches through interviews and systems mapping, integrated knowledge from multiple professionals and systems, and addressing public health problems, proposed strategies for improving and eliminating health inequities, and initiated a consensus building process across all the different departments to define shared problems. I ran into lots of barriers. One, we have a lot of different systems at our organization, and we're spread out geographically. That makes getting together a challenge. and had a lot of challenge not only coordinating interviews but getting people together to work on solutions. And a lot of the remote sites had unreliable internet connectivity, which again made it challenging to work on this. But we responded to those and were able to successfully come up with a great product at the end. So I got to practice some mixed method analysis, strengthen my relationships with a lot of the programs across our organization that I don't work with very regularly, and improve my understanding of the different system level access to care that we have at our organization. So this project has changed how I think about public health. At its core, even though it's just scheduling work, it is public health. It's about identifying who is and who isn't getting care, understanding why those exact gaps exist, and building systems that serve everyone more equitably. One of the key shifts for me was recognize that data alone doesn't tell the whole story. Numbers are important, but if it wasn't for all the interviews and the quotes and the day-to-day realities shared by the staff that revealed how patients and staff actually experience our system, that changed my view on things quite a bit. And their stories helped me see some of the barriers and opportunities in a way that just looking at the raw data couldn't. I also realized how essential it is to consider everything from the patient perspective. When we're working on the back end to improve processes like scheduling and the queue management, every missed appointment and all the confusing workflows represent real people who might be having a challenge and with accessing care and who are falling through the cracks. So throughout this project, I learned a lot of different important lessons that will continue to shape how I approach systems improvement and public health practice. When processes vary and by department and location, it's not just inefficient, it can sometimes result in inequitable access. Scheduling is a health equity tool, and who gets seen when and how often is shaped by the systems that we build. Informal collaborations, sometimes what keeps things running. When people trust each other and communicate effectively, the quality of care we provide improves, and so does the efficiencies. And finally, we need systems that don't just support our patients, but also support our staff. And coming up with sustainable improvements requires systems that are thoughtfully designed and make it easier for staff to do the right thing for patients and to be able to access the care they need. That concludes my presentation. Just want to thank my preceptor, the chief of staff at our organization, Dr. Ellen Hodges, all the YKHC colleagues. I think I probably had more than 40 different, close to 50 maybe, employees who helped me with this along the way, and then got some advice from UNMC professor Trina White. Guyana. Thank you.